the data repository issues will continue into Q1. And we will come to an agreement with them about how we handle that in terms of the contract, and follow that up with them. Obviously, in terms from a financial point of view, there's benefit to us, but in terms of planning, that does give us an issue. So we're expecting that to continue into Q1, and obviously keeping that under close conversation and monitoring with them as we go forward.
Mick, Simon, did you want to go? So let's go to Mick and then Simon.
I'd picked up the same issue, that increase in agency spending to 11, and I thought back to a previous conversation we talked about, some kind of additional controls put in place around agency spend. I just wondered whether those controls are yet to be implemented, or are they reflected in that position, which raises some concerns now that might be a different trajectory that might continue into next year.
So we have implemented an escalation framework around agency spend. So that's the rapid review that we now need to do, because we saw a positive impact of that in month 10, a negative impact in month 11. So we're reviewing that at the moment.
So still working through.
Yeah.
Thank you, Chair. I just wanted to ask about the private providers, because I think it's the first time it's been drawn out specifically. And it does seem quite stark in terms of near on 4 million against the budget of 1 million. And how far is that our capacity to meet demand? How far is it the acuity requiring private packages? And what are we kind of doing about it? And where does this feature in the kind of plan for next year? Because there's nothing to suggest it's not going to continue with this
What's me on that? So I think there's a couple of things here. One of them is some of the closure of beds that we had in our own provision throughout this year, which led to a real uptick in terms of the number of private providers that were being used. This also didn't come to light until the last sort of 6 weeks or so. So there is a deep dive review going on about this at the moment. What we have done is we have already started repatriating a significant number of people who've been placed in private provision back into Powys services. And there is a very clear drive that we have an action plan in place that drives this back down to what we would have expected this year, which would have been several million less than what we're seeing.
And where might the assurance reporting for that drive here?
So we've established a sort of complex and continuing healthcare programme board. It is one of the specific task and finish groups that are coming through that board. That's only been in existence for about the last month. So we are also expecting that there may well be some additional support that we look to receive around our complex care review, because we understand the significant financial pressures there and the targets that we've got to deliver. But there's already corrective actions going on, so we're already seeing a reduction in that. But we need to make sure we've learnt those lessons, and we've implemented different procedures to ensure that that doesn't unilaterally happen in one place anymore, but there is a process for approval of any of these private placements going forward.
Last bit. What are there lessons to learn about not knowing about this? Do you know what I mean? It seems a lot, but quite a big financial impact of something you're doing.
Yes.
Good.
And I would assume, therefore, Elaine, picking up on Simon's question in terms of board assurance, that this would come through DMP in some report or some way, shape or form. So yeah. Thank you. Kate wants to comment, then I will come back. And I know that I think Kirsty wants to come in as well. So, yeah.
Yeah, if I could just briefly about the month 11 agency use, then actually nursing, which is one of the things we've been most concerned about, is pretty stable. It's actually medical and dental, which has risen, and AHPs. And I can't speak for the AHPs, but the medical and dental will be mental health. And they've got fragilities, they've had sickness. We've got a tiny team. What I can say is there are checks in and rigorous checks
and that we have had some success in recruitment. We've got currently 2 or 3, I've lost count now, doctors being onboarded and potentially more to come. So I expect that to change quite quickly. So I think it's just important to draw out, it's not the nursing that we're really, really focused on, it's actually the medics that are pushing this up.
I think Mark wants to comment on this. Is it on this point? Mark?
Yes, yes, I mean, just to provide some assurance, hopefully, I think the increase that we've seen in reporting is down to a delay in capturing hours worked in previous months rather than there is an increase in the usage of agency. So we're actually not seeing more agency staff being used, but because of the way the information is captured and then reported, there is a delay sometimes with people submitting their rosters, and therefore those hours are getting accounted for in February, but perhaps worked in January and December. So it's much more level arrangement in terms of HEO. Indeed, that continuing downward trajectory. It's not as it looks like the spike that we're seeing because it's how it's been accounted for. But we're working with the services to make sure that we get that sorted so that it doesn't give this false narrative around the fact that it looks like there's an increase in agency use as opposed to a reporting type of delay. So hopefully that helps.
Thank you, Mark. Kirsty, would you like to come in, please?
Yes, it's with regards to the rapid review that you said about the escalation mechanism for signing off an agency staff. So I can confirm that because I've had mixed feedback from staff about using the system. So the staff on the ground are, using the system, and I've had positive comments and I've had less than positive comments about it. I'd just be interested to know whether that deep dive will look at potentially unintended consequences. When Steve and I were visiting the Llanwedog ward yesterday, experienced quite a high level of sickness, unfortunately, just pure bad luck. But the sickness and some acuity of patients has led to requests coming in, but the time it takes to clear the request means that sometimes by the time the request is approved, there are very few options to go to be able to secure the staff. So they perhaps then are leading to more expensive staff being procured because of the length of time it's taken. So I'm just wondering whether the review that you've mentioned will look at procedure and whether the procedure could be streamlined. It was very stark reminder to me yesterday to be told that we only have one appropriately qualified healthcare support worker in mental health available on the bank, one, which shows you the fragility of the ability to be able to backfill when people go sick. The fact that there is only one suitably qualified person available on the bank to reach to was quite a stark reminder really of how fragile some of the staffing structures are for us.
Okay, Elaine, we're going to go then to Ronnie and Mick, and then we will probably conclude this item. So please, Elaine.
No, thanks, Kirsty. Yes, the review, given that we have only recently put this escalation process in, the ambition with the review is that we look at the process and how that is being completed. We look at the reasons for the requests being made and the balance of those requests being made as well between different staffing groups. And we will then feed that also into what else do we need to do around possibly trying to recruit additional healthcare support workers to the bank or any other actions that we could do. What I would say around the timeline for that process, because I sign off almost all of them, so I'm signing off multiple of these every single day. I've done 2 while we've been in board today. So I think there can be times when that process is longer than we would want it to be, but it can also be quite a quick process. But I think it only takes it to have happened once that it takes a long time for a particular ward or area to feel really impacted by that. So we will look at all of those things.
Thank you. Ron.
Thank you. I have an observation. Elaine, I think this is for you, and I intend to be helpful. I serve on an audit committee for a housing association in South Wales, and it's one of the biggest housing associations in South Wales. And they too have suffered from drawing in agents. This is commonly, it's really purely to nurses. They've suffered some lack of consistency in bringing in nurses from a wide variety agencies. So what they have done now is to contract with one for a process for procurement, and the nurses that arrive as agency, they're trained to common standards because that's part of what one agency do. The HR processes are online, and overall it therefore gives a smoother and better experience. So I just wondered, does that sort of issue, does that sort of methodology offer any possibility for you?
I can see Claire looking at me as well, and Mark might well have comments also. I think it's incumbent on us to take lessons from anywhere. So if there are good lessons, let's look at them and let's implement them. I think what I would say is the single biggest area that we want to move through is stabilising our nursing workforce in particular. So substantive recruitment. So we know, for example, that if we could substantively recruit 40 nursing staff, we would save ourselves 2.5 million just by not having to pay the additional cost on the agency fee. So I think there is something for us going forward around that substantive recruitment, and we are looking in ward areas that are using regular levels of agency staff, what we could do to increase their establishment and recruit substantively there. But yes, very happy to take any and all examples of good practice from elsewhere. I didn't know if anybody else wanted to comment in that.
Yes. So we have a number of automated systems, including alerts to people who are on the bank to make sure that they are the first to get the ask if there is an availability of a shift. So we've got quite a good digitalized offer that makes sure that it makes it easy for people to accept and take up a shift for us. And the same for our recruitment processes, it's all done online. We've got fast track processes in place. Part of the challenges we do have is the nature of the offer. There are a number of pre-employment training requirements that individuals need. And individuals understand we were looking to do bank, their own availability means that they can't always come when we've got the training available. So it does cause delays then in terms of onboarding. But where we can, we've reviewed all of our systems to make them as straightforward as we can possibly do, so make it easy for people to start with us, but also move for us.
Thank you. So did you want to comment, Claire? No, that's fine. Thank you. You content, Ronnie?
That's fine. Yes, I mean, I'm happy to pass the information on.
Wonderful. Thank you. Finally to me.
Thanks, Carl. I build on Simon's point about kind of learning lessons. So I picked the report up about it, and it came a bit of a shock to me, actually. We reached the control tower at the end of the year because 2 months ago when we met, we weren't in any way certain to do that, and we didn't actually know how that was going to be achieved. And I think that kind of this report relies quite difficult, challenging, quite turbulent year we've just got. I just wonder whether there are lessons that we can learn from our experience this year we can take into next year, because it's not going to be any easier. So, I kind of reflected on, we started off not really knowing what the expectation was, uncertainty about what control technology was going to be. It became clear that we were starting to go off target, and we debated a number of times when was the right time to change direction, to make changes. I think we got to a position where, in truth, we probably left it too late to have the impact that was necessary to get back to the position we needed to be in. And we know how to then. I just think there's an awful lot of learning there. If you haven't already done it, we ought to kind of take a step back and think about what can we learn from this year that we could carry forward. So, and if you've already done that,
No, it's not a
opportunity to.
very important point. Thank you, mate. Hayley, is it you or Pete or?
I'm happy to come in. I think it'd be very important in, obviously, just this morning we agreed the plan this year in terms of how we bring that learning into this discussion in Q1, and also the timeliness of that decision making that we do reflect as a whole board on those arrangements. So I think it's a helpful suggestion. I think we need to make it a substantive discussion item in one of the committees. So that's from DP.
So just to be clear, when I said we, that wasn't to you.
Yeah,
Collective.
yeah.
Yeah.
So the suggestion is we have a DMP focus on this. I'm just wondering, Helen, as well, whether some board development time as well may be helpful.
Look, I agree entirely. I think it'd be very helpful. So we do, perhaps there's a bit of detail and work we can do, and then we can reflect as a whole.
Thank you. The recommendation is that we receive the financial report, that we are assured that the organisation has effective financial monitoring and reporting mechanisms in place, and that we note that the forecast that the Health Board will achieve the financial plan of a 15.8 million deficit. However, the underlying deficit is assessed as 30.6 million. Does anybody want to not support that recommendation? That too is supported. We will go to item 4.2. We are due to break at 1 o'clock. So it may be that we have this item presented or introduced, and then after lunch we will come back to discuss it and to respond. It's the Integrated Quality and Performance Report, and we're back with you, Nicola.
Thank you, Chair. In the interest of time, and because there's a lot of themes that are similar to the last time this report was presented to the board, I am going to report it quite briefly and more on an exception basis. Our good provider performance is represented in the report, as we've seen in previous months, for both plan care measures, therapies, with diagnostics showing an improving picture, and cancer as a provider maintaining the performance that we've seen in previous months. As with previous months, there's some fragility in the mental health measures, particularly Part 1A and Part 1B. Due to the small teams in those areas, it does mean there's a sickness in that particular team, then that measure can decrease in ranks, but overall it has improved. And as you can see, there's assurance that it did improve in February, which obviously we know that, it being now March, and you'll see that in the next report. And we're maintaining good performance in terms of access to psychological therapies and in terms of pain treatment planning. And for mental health measures, as they apply to children and young people, good performance across the board. With regard to new and developmental services for children and young people, whilst this report, which is a retrospective report showing January's performance, those measures weren't improved at that stage, I can assure the board that we have achieved the 0 over 104-week waiters by the end of March, using additional Welsh Government monies and insourcing, but also because there's been a lot of work through the escalation process in terms of remodelling the service based on the 8 national standards, and putting in an NPT approach and triaging the patients. And as a result, an internal waiting that we previously had to close those cases has in March has been reported as no longer existing, and that means that all the capacity is being used for the return, the referral to treatment patients. So again, the board will see that coming through in future reports. In terms of our MIUs, and there's a report later on the agenda around temporary service changes, our performance remains good and part of the ongoing evaluation, which we'll talk about later. With regard to commissioner performance, that variability in terms of weights, again, the board has seen that in previous reports, and that remains. We are in close conversation with Robert Jones and Agnes Hunt about their trajectories, and again looking for assurance on delivery of the 104-week rate with them, and cancer pathways and A&E targets remain under review, not meeting the targets in our commission services at present. So that's where I was going to leave the presentation of the report, Chair, and I'll hand back to yourself.
Thank you. So we do have a little bit of time before lunch for discussion. Please, Robert.
Yeah, I think in light of the temporary changes on the centres for strokes and the likely changes in the future, it would be useful, I think, to have Amber 1 information as well. I've got a one liner with red calls. Is it down there? I can't. Anyway, it's part of your one line there because obviously that's a stroke is included under Amber.
Thank you, Robert. Happy to include that if it's not ready to be included in the future.
Thank you. So Steve and then Kirsty.
Thanks. Just in terms of planned care commission services, you referred to tracking the ongoing effectiveness of the additional funding that's gone to large providers. Can you just give a comment about that and whether we're confident that we are getting the adequate benefit for Powys residents from that funding that hasn't come to us?
Thank you. Obviously, the board are aware that that funding is centrally deployed to providers rather than through ourselves as a commissioner. The latest report we've had is that there are, I think, 3 health boards that won't meet the 104-week rate by the end of March. We have asked for trajectory to our patients. Some of our patients are experiencing those long waits and will continue to do so. And obviously, we know Welsh Government have asked for further assurance from all of those providers into next year, and we've asked for those trajectories as well. So unfortunately, some of the Welsh providers are unable to meet that rate of time at present.
So is the funding not then being used to
Well,
generate benefit?
I think that would probably be something that Welsh Government would be better answering than ourselves.
Right.
Kirsty, would you like to?
Yeah, I just wanted to comment on the improvements on children's ND. Now, on the face of it, the 2-year wait is still a really, really long time. But what had happened was we were starting assessments to kind of like hit the target, and then we're holding a substantial internal waiting list, which wasn't really visible. And the fact that we've been able to get rid of the internal waiting list is you know, it's not a small thing to have been able to have done. So I just think that we should recognise that. And what's also really important is that the team, I think, is not just going for the target, but actually is in making sure the service is designed alongside the standards. So we know what a good service should look like. It's a service that goes beyond just the simple measure of the waiting time. And so the team are working really hard to make sure not only the service is accessible, but once the service is accessed, it's a really, really good service and it meets the standards you would expect. And so I think we've still got a long way to go, as we've seen this morning, to get anywhere near the 28 weeks. But I do think it's important to recognise that this escalation framework has been really useful in getting us to where we are now. So that system that we've put in place is effective and impactful.
And thank you, Kirsty. Of course, it has been noted as well that our ability to improve on that will be dependent on additional funding and so on. How likely is that?
Well, who knows? So we got to where we are because we've been able to, the team was successful in bidding funding. So they were able to attract more funding in to develop plans. I mean, whether that fund will be available going forward, it's impossible really to know. So it's precarious, but I do feel quite confident that the system that we've got is a more robust system. So we'll be able to maintain. Whether we can make further improvements is the challenge, but we'll be able to at least maintain where we are.
Yeah.
Yes, if I could just come in on that, thank you, Kirsty. And I think it is right that we recognise that these improvements have been about really focusing on the children and young people and their families. And, you know, we have, you know, had to watch our RDT performance deteriorate in the last few months while we've undertaken these improvements. But that, you know, that has been about putting children and people and families at the centre of our improvements. It's been no small feat to be able to address the backlog of children that we had on the list, with over 538 children being seen in a 9-month period, just off that list, not off everything else. I think it's also really important that we're now in a position where we can much better understand our demand and capacity, and that by improving our pathways aligned to the standards, that actually we will reduce demand. So one of the things that we have introduced is a triage approach, and even in the short time of doing that triage, our referral to acceptance is reduced from 99%. So we were accepting 99% of all our referrals into that service. It's now dropped to 70%. So there's something about, and that's not only important in terms of us being able to see those children that need a medical type assessment, health pathway of care in a timely way, but it's also really important that those children that don't require that, but require something else, we can make sure that they're signposted to an appropriate pathway. So I think this is more than just numbers. This is about the right child being in the right place. We still have got a long way to go, but you know, I do feel that we've worked extremely hard to be able to build the foundations in order to be able to continue with those improvements.
Thank you. Mick, did you want to come in? Did I see your hand up earlier? Okay, forgive me. So I think we'll take a break now. There may be more discussion on this report after lunch, so we'll see where we get. We have got 45 minutes scheduled for lunch. I don't want to give everybody or anybody indigestion, but if 30 minutes were sufficient, then we could start as soon around about or after 1:30. That would be helpful. But I'm in your hands, but if you could get back as soon as possible after 1:30, then that would be helpful. Bon appetit. Croeso nôl, hyfryd i'ch gweld chi i gyd unwaith yn rhagor ac dyn ni yn ail gychwyn ein cyfarfod trwy ail fideo yn yr eitem 4.2 ar ein agenda. So welcome one and all after the lunch break. We're going to take up again the discussion under 4.2 of our agenda that we started before the lunch break on the integrated quality and performance report. So does anybody else want to contribute to this discussion? Lunch has obviously pleased everyone so much that that people are really content. So Ronnie, please.
Thanks. Just looking at the summary for months 10 plan care. It seems to me that we've had that one endoscopy hanging around for a very long time. And of course, it may not be the same endoscopy rate. I don't know that, but there always seems that that minor deviation of one figure. And I wondered, what's the background to this? Do we know anything more about it? Similarly, of course, they've always been around that same sort of level. It's all a bit, but not substantial.
Sorry, I missed the second point you made, Ronnie. There was the endoscopy pathway, then
Echocardiogram.
Echocardiograms. Okay. Yeah.
So the specific details of the individual, I don't know, but what has been shared is that there is a large number of people who can go through the pathway and it's reasonably routine. There are a few specific cases where there will be particular complexities or preferences that stretch out that waiting time. I can look in and check on the specific details for you. Part of the work that we've been doing is everything that we can to try and reduce that wait, reduce the people waiting longer than we would want them to. But I'm happy to pick that up.
Okay, I think my point is it's possible to resolve small numbers reasonably quickly, then we'd be reproducing a positive.
I think it relates to the complexity of a very small number of people that lead to that longer wait, but I'll confirm that and come back on it.
Okay.
I can probably just add that for the provider service, we treat the low complexity cases, and that's within our gift to get through. There will be some that are more, as Elaine says, more complex or require commission services to deliver.
Sure.
And they can be more, so it's probably this one sticky one that's hard to resolve. I don't know why. But it's less within our gift.
Thank you.
Thank you. So if there are no other contributions to this item, we are asked to receive, to discuss the content of the report. We've done that. And to be assured that the Health Board has appropriate systems in place to monitor performance and respond to relevant issues. Given the way we normally deal with these things, yet again, does anyone want to indicate that they don't support the recommendation? That is supported. So we move on to item 4.3 on our agenda. We're back with Nicola and the annual delivery plan Q3 report.
Thank you, Chair. So this is the quarterly report on delivery of the 24-25 plan as at Q3 and as at discussed and assured through the PPH committee. Hopefully the format is familiar, but we've also now included those achievements which affect our patients, population, staff as a summary in the report as well. And we'll follow in with feedback from the committee, and we'll do that going forward. And when you see the Q4 report, we'll do that as a sort of annual summary of the plan. And hopefully use that as part of our annual report as well. But as at Q3, there's good assurance on the delivery of the 24-25 plan. with a summary of those actions and deliverables complete. But most importantly, that forward look on assurance of high or medium assurance on delivery plan overall for the year as well. And as I say, we've done that summary of achievements because to make the plan come to life a bit more, what difference have been made. And also there is the actions that are were red rated at Q3, the reasons for the delay or the mitigations, as well summarised in the plan in the paper on pages 4 and 5. So that's all I wanted to say in terms of introduction, Chair, and happy to come back.
Colleagues, any comments, questions on this report? Nick, please.
But there's a huge amount of work being undertaken, some very substantial achievements on that, and that's credit to everybody involved. But inevitably, you turn to the.
Sorry, we got the noise of the fan as well, and so we could, yeah, please carry on.
So just acknowledging the huge amount of work that's been undertaken, substantial achievements. Inevitably, it's the 26% kind of deficit in the outturn that jumps out at you. And I suppose just a question really, is that a kind of reasonable position? Are we satisfied that is a reasonable point to get at if that's where we are at the end of the year? So I can see the individual reasons for slippage. Some things outside our control, changing priorities, funding that didn't come through, some capacity issues, but it just raised a question in my mind. Is there any kind of system issues? Is that 26%, if that's what it turns out to be, a reasonable position? Or were we over ambitious? Is there a level of underachievement? Do we understand that? Programme management issue. So it's just a question really, are there any lessons that we can learn from this year's outturn that we could carry forward to next year, which is undoubtedly going to be just as, significant a challenge as this one?
Thank you, Mick. I think it is a question that we ask ourselves all the time, as we said, in the context of the plan for 25-26. That balance of ambition and deliverability is a question we're asking all the time. And I think we always ask ourselves about, did we have optimism bias, which we know can be a feature of planning. I think in terms of our learning going into 25-26, there was a theme maybe of some difficulties in the interface with the national digital programmes and our own plan. You can see that there's a cluster of those in that group. So we've tested that really hard again in the 25-26 plan. And some areas that again were dependent on national funding that didn't come through as well. So I think those interfaces with sort of national plans and funds, an area of learning for us that we've taken forward. My reflection from other health boards is around 20%, because of the complexity and the breadth of the service and commissioning delivery that we've got. Does seem to be that flex in years. So I wouldn't say from my own experience it's out of line with other health boards, but we always look at it and build on that learning into next year. But thank you for the question.
Yeah.
Thanks, Chair. First of all, I'd just like to say that there's some really good news in this report. I draw attention, I think, particularly to the establishing of the integrated autism service and the ADHD services. Obviously, the children and adolescent mental health services as well. I think that's really positive. I got some questions around the I guess around some of the digital stuff, because it strikes me that there's some things being held back. Some of them seem to be internal, but some of them seem to be held back because of national hold-ups. And I just wonder how we were kind of managing that, because I think digital transformation is something I we should rightly put some faith in order to make our systems better, and perhaps even to save us money over time. So I was just wondering what the kind of feeling was around this balance between the internal and the external things that are holding us back.
Shall I come in on that? So I think that two things. There's been a separate review of the national digital programmes that have taken place fairly recently, and a new digital transformation steering group established for the whole of Wales to drive forward those national programmes. The terms of reference of that has been developed, and I will be expected as Chief Exec to attend that alongside of the Chief Executives of Health Boards and Trusts across Wales. So that is a new mechanism that's come out from the review, and that will assist us in understanding the overall picture nationally a little bit better. But I think the issue around deliverability for us in relation to this is, I just wanted to mention, this is a Q3 progress report, and Q4, you'll see there's a delivery confidence assessment as part of this as well. So I think the point that Nick has raised is important, that we'll probably do the lessons learned once we know where we land by the end of the financial year, because although we're in March, in terms of the completion of that assessment against the actions and the relevant performance delivery against our plan, we'll be doing that after the end of the financial year. So really important points, but I'm hoping that the new arrangement around overseeing those national digital requirements will assist us in getting a better alignment between our local activity and planning that in the context of the capacity to deliver nationally.
Okay, thank you.
Thank you. Okay, I can't see that there are any more questions or comments in relation to this report. So we are asked to consider the report ahead of submission to Welsh Government, and to be assured that there is a process in place for monitoring progress against plan. I'll pause so that should anyone want to indicate that they don't support the recommendation, you have an opportunity to do so. That too is supported, thank you. We turn to item 4.4, and the medical director is going to introduce this update report on the temporary service changes. Thank you, Kate.
Thank you, Carl. And so this is a report, as promised, just to update on the evaluation and monitoring of the temporary service changes that were introduced at the end of 2024, both for the MIU service and for co-location on the wards. So it's an update on the evaluation, monitoring and the mitigation plan. So just to confirm that the monitoring is in place, the temporary service change board and the evaluation and monitoring group are meeting. A dashboard has been developed which is actively monitoring the areas that were agreed as key points for progress and for monitoring and evaluation. As we agreed at the beginning, given the small numbers, we will not be looking at that in detail until the end of the 6-month period. But I am assured that it's being looked at actively and is being gathered. We also agreed that at the 3 and 6 month points, then additional questioning and questionnaires would be sent out to key stakeholders, that's primary care, third sector, social care feedback, staff experience and service user patient stories. So the 3-month questionnaire has been sent out and is being currently looked at. So just to confirm that all the expected and anticipated monitoring evaluation is underway and is taking place. The mitigation plan is presented, and just to confirm that all mitigation is in place and is ongoing. So further to that, then we have a summary of the further steps, and that will be that the Service Change Programme Board and the Evaluation Monitoring Group will continue to monitor into the summer. We'll be looking at the data as it is presented, and then we'll bring back the information to board on the 30th of July for further discussion and decision making. So in terms of any significant positive or adverse effects, then there have been non-significant. The minor injuries units are running very smoothly. There have been, I think I can say, no unexpected closures as a result of the changes. We had the radiology project at the same time, so there has been some change in service, but that's been for an entirely different reason. The length of stay is continuing to fall. No additional risks have been identified. And in terms of stakeholder feedback, then we have had some really helpful feedback from primary care colleagues on a few matters, which are really around communication between clinical teams on transfer of patients. So there's been helpful feedback, which is helpful. In fact, some of that would probably have been an issue before changes were made, but it's been helpful in terms of us helping to refine the model.
I just wondered whether it might be helpful for this agenda item, because I think I said at our last meeting that we've done a number of visits now to get the patient's perspective, I suppose. Just for you to know, we haven't had any complaints relating to the MIU changes that have taken place. And then on the 11th and 14th of March, we were in Llanidloes and Brontfleet, and although the report hasn't been prepared, if I just share a couple of observations, if that's all right, Chair. There was a high satisfaction, people loved the flexible visiting, there was a relaxed atmosphere. The food quality and choice was great, staff were kind, attentive, helpful, noticeably different to a larger hospital. Social interactions were appreciated. The people spoken to understood the purpose of the unit, and they felt that the exercise sessions were really appreciated and focused on staying active and maintaining independence, and were very beneficial for their morale and mobility. We visited the stroke ward in Newtown on the 27th of January. Again, we just haven't produced the report yet, but 2 comments. The service has been terrific and the nurses are lovely and very patient. There clearly are a number of things that have come out of that as well, about the delays of moving on and that sort of thing, but we'll pick those up in the report. But I just thought it was really important to share that feedback, that we have actually been in and spoken to patients and had some really, really lovely comments.
Thank you, Katie, and certainly that resident. I think I said at the last board meeting, Kirsty and I have also visited the Ready to Go Home units, and you know, there's a resonance between the feedback that we've had as well, and the information that you're sharing, Katie. So thank you very much for that. Does anyone want to comment on this temporary service change update report? We will, of course, receive the full evaluation for consideration at our July meeting, when we will need to consider the future of these changes. But please, Ronnie.
Just to say, I picked that up as an issue when visiting Andrew Block and MIU yesterday, and the feedback from the staff was that it was working really well. Unfortunately, there wasn't the opportunity to actually speak to any patients, which I love doing. That's always for me one of the great pleasures and a privilege, but there just weren't any available. And so it would have been nice to have triangulated that. But the feedback from the staff was good.
Thank you, Ronnie. Well, thank you, Kate. So we're asked to receive the update on progress to date, including the evaluation and monitoring plan, and to be assured in relation to the mitigation plan. So please indicate if you don't support the recommendation. That is supported, which takes us to item 4.5 and the corporate risk register. And I'm going to invite Stella to introduce this item. Thank you, Stella.
Thank you, Chair. Yes, presented is the March iteration of the corporate risk register, and as with previous reports, risks 11, 8 and 12 will be considered in committee due to their sensitive nature. We are proposing 2 changes to the risks for this update, the first being CRR 001, the financial forecast. We're suggesting a decrease in risk score from 20 to 16 as a result, in a reduced likelihood from 5 to 3. And that's as a result of the expectation that the Health Board will achieve its planned deficit in year. Just to flag that this is an in-year risk, so we will reassess this for next year as part of a wider refresh of strategic risk. The second change proposed is to CRR 007, and that's in relation to primary care. We're suggesting that the score increases from 16 to 20, and that's a result of an increase in impact from 4 to 5. And that's as a result of some potential instability with the Shropdock out of hours contract,
practice sustainability applications being prepared by Land Vashlin, Knighton and Pristine practices, and dental access and waiting list issues in the mid cluster. There are no other changes proposed to the risk register at this stage, though just to note that we will be undertaking development of new strategic risks in light of the new risk management framework and integrated plan with executive directors over the coming weeks, in readiness for presentation to the board in May, alongside a closure report for the current corporate risks. We'll also be developing an organisational risk register that will focus on high-level operational risks, and when developed, this will be reported to the board as an appendix to the strategic risk register of all cited risks. I wasn't planning on saying anything further, if that's okay.
That's fine, thank you. So I think you've highlighted the important and salient points of the report. Thank you very much for that. Colleagues, does anybody want to comment on this report? Please, Meg.
Just a minor presentation issue. So, you know, helpfully the key changes are highlighted in the report, but you often look at these, it's very difficult to distinguish between this one and the last one you read 2 months and 2 months before that. And I wondered whether it's possible to kind of highlight what changed between this one and the last one, not in terms of the high level issues, but the kind of mitigation and the controls that sit beneath it. And, you know, even if it was just in red, if it changed, that'd be really helpful.
Thank you.
Yeah.
You take that on board?
Yeah,
Thank you, Sarah. I just noticed on screen that Nina has left us, and it may be that she needed to leave and I see. So so I just didn't want to continue if we just lost connection with her, but absolutely fine. Thank you. Please, Simon. Yeah.
Can I just check the limited shorts on the Shrop Dog? Is that because of the slightly tenuous nature of the contract, or I thought we renewed the contract and therefore it was stable again? So I just wondering why, is it a timing issue?
Yeah, please.
So in terms of Shop Dock and in terms of the timing of this report,
Yeah.
we were in the process of negotiating that contractual change.
Okay.
That's now resolved and actually it's sitting with Hayley for signing.
So this would move from limited to reasonable post-signing?
That is one factor.
Okay.
So if you recall, there were other factors in this around primary care sustainability application.
Okay.
Yes.
Okay. All right.
Can't see any other hands, so we will consider the recommendation that we review the March 25 corporate risk register update, that we be assured on the controls and assurances to manage strategic risks, and that there are actions to address any identified gaps, that we note that work is underway to develop the 25-26 strategic risk register in accordance with the revised risk management framework that we considered earlier in our meeting, and of course in accordance with the integrated plan that also we have dealt with in this meeting. So once again, please indicate if you are not content to support the recommendation. That's supported, thank you. And so Katie, item 4.6, we turn to you for your report. Thank you.
Thank you, Chair. And I'm just going to pick up a couple of things that have happened since I wrote this report. Predominantly, we've got 3 national projects that we've undertaken this year, which are we're reporting on: care closer to home, unpaid carers and travel time. So we will be publishing those reports for completion by the end of, well, by Monday, I suppose. I've also just received into my inbox today the report from the Hay and Talgarth visit, which we will be sharing. The Health Board have had an input into the action plan, so the local authority in the third sector. We've had a few issues around staffing capacity since December, so I'm sorry that's a bit delayed, but anyway, it's on its way out for publication.
You can see there that I've attached the emergency care, urgent care and ED report, which has received quite a lot of coverage. Obviously in Powys, we visited the MIU units in Powys, and we're very grateful. We visited them twice, very grateful for the support of the teams welcoming us and us being able to feed back in. For planning next year, I've shared with you what our local priorities are. They're all subject to approval. We continue to work on the basis of the 13 localities, which I think is the adopted approach really across the whole of Powys. Just to draw members' attention to the fact that in September we're planning to host a health and social care summit, probably in Llandrindod, and I've already been in discussions with the health board team and the local authority team as to how and what that might look like. And it will probably be around planning for the future and what the priorities are going forward. I think just the final thing really, I suppose, to say is it was interesting this morning having the discussion about the annual plan. Nina's gone there, but I'm having discussions with the health board about their annual plan, and I'm having discussions with the local authority about their annual plan. And it strikes me that this is very much about the patient at the heart of this, and it's about how both those plans can be aligned and whether we actually get to a point with the health and social care plan, which is for Powys. And I still think there's a little bit of work to do with that. And maybe that's a focus for the summit in September, is trying to help unpack some of those issues that may or may not be real. So that's all I want to say, Carl, but I'm happy to take any questions.
Thank you, appreciate it. Robert?
I'd just like to make a commentary. I'd like to thank Fleiss for, acting as a sort of litmus paper really for patient experiences and complementing the surveys we make on our own provision. Getting urgent and emergency healthcare in hospitals report, I find quite sobering and distressing as well. And mostly because it's exactly what we're hearing from, people we know, family we take, and of course the feedback for residents. Goodness knows what would happen to the red cold response rates if people didn't, take their own relatives to hospitals. And although EDs are not directly within our control, we do pay for those services, and and it's very important, whether the news is good or bad, we continue to receive the summed experience of patients in this way. It's very important that we expose ourselves to that, because that's what people are experiencing. So thank you very much again.
Thank you, Robert. So Stephen and Mick.
Yeah, can I just follow on from that? And this maybe a question for you, Katie, or other colleagues. But what I found the report you produced really helpful, but it then begs the question about the large number of patients that receive emergency care in English hospitals, and how we get assurance about the experience that they're receiving, because presumably Schleiss doesn't have a remit over the border. So I just wondered how we're able to get experience of our residents seeking the care outside of Wales.
Well, you're right, it's not in legislation, but we do have a very good working relationship with the hospitals over the border. I think it probably stems from Future Fit and all of that we went through. We did consider going into the hospitals, into Hereford and then to Shrewsbury and to Telford and to Robert Jones. It was just a capacity thing, but we will make sure that we, pick up those viewpoints over the next year, because the point you make is absolutely right.
I mean, Robert said what I wanted to say far more eloquently than I would have done it. But this was a really impactful report, and as I read it, I thought, what will we do? We'll say, well, thanks, Katie. We know the contents of the report. That just didn't seem adequate, because in those 2 pages, I followed up in kind of a graphical way. Is what, as Robert said, intuitively what we know to be the case. And we were talking last night about patient stories. Claire recounted a particular patient story that was so impacted on the board that she worked with, that it kind of lasted for many years. It came back to the top point. terms of, you know, guiding their kind of thinking going forward. And this just feels to me like something of significance that we could use as a touch point. It wouldn't be adequate to say thanks, Katie. No, how can we use this in a positive way to help get guide what intuitively you know needs to be done?
Yeah, I completely agree, and I think it's about how we take the findings from this work and integrate it in the work that we're doing, for example, through our contract quality performance meetings with our providers in Wales. But also we know there are similar patterns to the experiences described in this report from other parts, including England. So it's how do we use that? It will be something to work through, and it ties to the conversation earlier about the PECS committee, the civic patient experience and triangulation of all the information. So I agree, it's not about noting it today, but about the next steps, about how we take forward this report as a commissioner to take insights forward. I just think one issue that Katie raised, which was the challenge about a joint health and care plan, I think we've got to recognise there are some elements that the Venn diagram, the bits in the middle, which are absolutely essential, and then there are other elements which are slightly different, and we've got different statutory requirements in terms of our planning expectations back, both in terms of the county council and their corporate planning arrangements, and then for us in the discussion we had earlier today around annual plan this year going back to Welsh Government. But I just want to give some reassurance or assurance that the joint leadership team that we've established, we've specifically discussed about how do we join together on a number of facts, including the work that they're undertaking with the local authority on sustainable Powys and the work that we're doing better together, but also on basic things like the engagement approach that we take. So the next round in May of town and community council meetings, how do we do that collectively across? So I think there's more work to be done, but I think we are in the right place in setting that ambition. But I don't think we'll ever get a fully joined up health and social care plan. It may be a language issue. There will be bits in the middle which absolutely need to be joined up, but there will still be requirements slightly different for us at an organisational level. But that system focus is also in the OPP space as well.
Yeah.
Kirsten, I think just on that, Katie, you mentioned the summit, as it were, that you're really pleased to learn that you're in conversation with relevant colleagues within Health Board, because of course, as we take forward our Better Together programme, our engagement with the population, the public, is going to be quite important. So there is alignment there. That's the important thing. That's what you're telling us. Yeah, thank you. Kirsty, would you like to comment, please?
Just reflecting on this point about saying thank you to Katie is not enough, but what can we do? And there are those formal mechanisms that Hayley just described. But I think Carl and I have been arranging, and I've got more to arrange, visits to our neighbouring services. So when we went to Wye Valley, we did go to the ED department and have a look around the ED department in Hereford and understand how ED was functioning. We were on our way to Cwmtwal. We think it's an opportunity to think about how Merthyr is coping. We've got a delay to take to Swansea, but again, an opportunity to think about Morris. So I think that's another mechanism in which we can. But for me, it's how can we use that report from the advice to really spur us on in alternatives, because we know there will be people who have those ED experiences who didn't need to have them. They're in the ED because of a failure somewhere else in the system, and that's usually a failure in community services. So if you've been sent to Morriston, catheterisation by the ED department, that should never happen to you. If you're in the ED department because somebody in primary care didn't have a service else to do, but was worried about you and sent you in, those are the patients that are waiting the longest. The people who've got road traffic accidents and acute heart to cardiac arrest are being seen. But those patients who can be safe, not safe, but more safely left in the ED department are the ones that are having that worst experience. And that should spur us on to design, when we're thinking about our own services, to design them in a way that prevents people from going to ED, to have that experience taught. So I think that's a good way we should use that report, is to remind ourselves of designing services that will stop that happening.
Please, I'm reminded, Kirsty, that not long ago we did have outline plans for MIU plus. So I don't think we have to invent something new. How you would staff that, pay for that, I don't know, but there are in principle plans there.
Yeah, principal plans, and when you sit and listen to a story about somebody that's been sent in because they couldn't have their catheters changed from their care home, then you just shows the fragility. I'm not saying that's our service, but the fragility of services in community, and that should help us inform our model.
Thank you. So just so we've made, or the point has been very effectively and strongly made about, it's not just a matter of saying thank you for the report, but how does this spur us into implementing action that takes things forward. Hayley, you very helpfully described existing mechanisms that this report will help to inform those contractual quality performance improvement mechanisms. And so I suppose my thought is, right, so given we've received that assurance, is that enough, or is there anything additional that that we should be, I'm not necessarily saying that there should be, but is there anything additional we want to identify that we want to put in place as a result of this conversation today? No, that's fine, absolutely fine. I just want to give people that opportunity to say, yeah, we're assured that this will be taken forward. The existing mechanisms will drive forward the necessary improvement, and now you've got a quizzical look on your face, Ronnie, and Mick wants to come in as well.
That's just my natural face. I suppose what I was just doing was reflecting on Hayley's point about interlocking Venn diagrams. I'm a big fan of interlocking Venn diagrams, because actually what you can do, the stuff in the middle, just get lots of achievement really quickly and purposefully. And I just wonder if it's possible to have that described in some way. Would others find that helpful? I don't know.
Okay, we'll have a go, Ronnie, and I think that the issue for me with that is that two things really. It's about we need to discuss scope, I think, Carl. So perhaps we could take an action to look at the scope of this piece of work so we get it right, because I've got something around the discussions around patient experience with the current service model, which is really the description of the report from Powys, versus the interlocking of the model going forward, which is what parts need to be together and the parts. So if we could think about scope to respond to that, Ronnie, we can bring it back to the relevant committee. But we have key items like on Monday I'm going to a summit with the Cabinet Secretary, as are all hospital organisations in Wales, to talk about women's planning and our learning from this year going into next. So there'll be a number of opportunities to bring back the assurances through planned pieces of work. I just need to work out which way to do that. That's okay.
Thank you very much. Mick.
I was just reflecting on your question, Carl. What could we do to do something different? Just noting it. So I suppose this is kind of a mega story, supersized patient story, and when patient stories work well, they end when the story is told. It's the following that matters. And a couple of organisations, 12 months down the line, we've revisited patient stories to show them changed as a result of that, and maybe there's an opportunity here through a board development day to invite Katie back in 12 months' time to say, this is what's changed.
Yeah, thank you. So that's really helpful, and that we'll take that as an action. So thank you, Katie. We received Katie's report. We turn to our consent agenda, and as I explained earlier, these are items that don't need discussion, and we've already, in principle at least, agreed that we will approve them en bloc, and I'm assuming that therefore we do that, unless anyone wants to say otherwise. In which case, we come to the end of our meeting, to item 6. I'm not aware of any other business, therefore I assume there isn't any. The date of our next meeting is the 21st of May, and therefore that concludes the business for our meeting today, and it simply remains for me to, as always, thank everybody who has worked so hard in preparing for today's meeting, preparing the information, but all the work that was behind the scenes by the executive team, by the corporate governance team, and indeed by other officers and colleagues across the organisation. Absolutely noted and much appreciated. And that concludes the meeting.